I'm Dr. Michael DeTola.
And I'm Megan Strong.
In today's case of the week, a shortcut that some dentists like to take really infuriates one of our technical advisors.
And forget giving out toothbrushes to your patients. After this story, you're going to want to keep them all.
That and more on today's Chairside Live. Hey now, hello and welcome to episode 138 of Chairside Live. We've got a great episode for you today and a good case of the week. But first, hello Megan.
Hello. Last week you said that we were waiting on iTunes approval for your new podcast. Where are we at? What do we got?
We have been approved by the nice people at iTunes. So since I know you are absolutely interested,
yes,
you can go to iTunes, to the podcast section, and search for Accidental Geniuses, or you can launch the podcast app and do it. Or you can go to Stitcher, it's available there as well. Or you can go to the website, which is accidentalegeniuspod.com. But probably iTunes is easiest way to do it. And first episode is officially up, and the next second one's going to drop in the next day or two. And it's me and Josh dishing. Guy talk. Talking.
Nothing like it.
Two dentists talking about, at times, more about what it's like to be a dentist, than actual specific like dentistry stuff. But we have some future episodes scheduled for specific dental topics and talking about how we handle clinical stuff. But the rest of the time, it's complaining about staff, them complaining about us, things like that.
Good times.
Josh and his girlfriend work in very different dental environments, and he has his own practice, and she's with a Pacific Dental affiliated practice. So it's really interesting to hear the interplay between how these two young dentists, which is defined as less than 10 years out of school, are handling, coming into the dental profession and trying to carve out their own little niche and be able to do all the things that professionals want to be able to do, fund retirement plans, college funds for the kids. So it's good. You have the perspective of me, the older dentist, and then the younger dentist as well. So hopefully people will check that out and listen to it, because we sure have fun doing it. Anything exciting in your life?
I'm back to eating anything that I want.
Oh, good.
Yeah, so if you missed, and yes, that is the most exciting thing in my life right now, the fact that I can have butter and dairy. Which butter is dairy? You know what I mean. It's been a long 9 months here, people. Has it been 9 months, 11 months, anything? Right. I don't know. It's been a while. But
all the restrictions are
all the restrictions have been lifted, and I feel like the chains have been lifted.
Oh, perfect.
I'm back to binge.
Did you celebrate with a stick of butter?
I did. I went to celebrate. I went to a restaurant that I know you love, the Playground here locally, and it was fantastic.
Yeah, a lot of butter there.
A lot of butter.
A lot of butter. You don't see it, but it's the reason the food's so delicious. All right, cool. Well, we've got an interesting case of the week for you this week. Usually I go pick it out myself, but this time, as you'll see, one of our technical advisors grabbed me and said, hey, this is what you're talking about this week. This is something that dentists need to work on, because it makes our life really, really difficult. And so I couldn't say anything but yes. So let's take a look at her all-request case of the week. Usually I go walk onto the lab floor and look for a case of the week, but this week I was walking down the hall minding my own business when one of the technical service advisors from the all-ceramic department grabbed me and said, you have to talk about this on Chairside Live today. And she seemed angry. And I said, what's the matter? And she said, we have to put a stop to this. I said, what is it? And she said, dentists using double arch trays for bridges. And I said, oh yeah, that's kind of a no-no, definitely. And she said, there's times where these cases are bad, and then there's times where they are worse. And so we're going to start, just for example, on this one. This one caught my eye too because of the three different colors of impression material. We've got the blue, the purple, and then we have this brownish one here. You can see it over here. It's definitely some sort of polyvinyl material that was added really just to the bicuspid and not to the molar. And then when you see the solid model, you can see why. The margins here are pretty much, well, not quite equigingival on the distal, but on the rest of that tooth. But then on the bicuspid, they are way down there. In fact, I think I see foramen ovale down there with the trigeminal nerve coming out of it, or some state board question like that. But considering how deep that is, you can kind of almost see a fair part of the margin there. But anyway, that looks like why probably this impression was relined one last time to try to get down there. I'm guessing if we pulled that out, we would see that it didn't quite get all the way down there on that impression. But be that as it may, here's what that looks like when it's poured up and mounted. And so not that many teeth to use for lateral excursions here. But as the technical service advisor pointed out to me, this one's actually okay. You know, I mean, it's at least not going to have to be sent back to the doctor because even though we're kind of close on the reduction over here for this Bruxer bridge. But she said, look at the wear facets. At least we know when we close this down into place based on those wear facets, you know, that the bite is pretty much in the right place. And so even though they hate doing this and they don't like having to do excursions and feel like they're doing a lot of guessing, she said at least with natural teeth here with wear facets, it makes it a little easier on us, contrasted to a case that we'll see next when we look at that one. The interesting thing about this Bruxer bridge is that the dentist actually prescribed Bruxer anterior for this bridge. That's the new, more aesthetic version of Bruxer. And the reason it's called Bruxer anterior is because it's not as strong as the regular Bruxer, but it's more aesthetic, and so it's meant to go in the anterior. There was talk about whether or not we should name it Bruxer aesthetic, but we realized that a lot of people would probably want to use it in the posterior and say, oh, let me use the more aesthetic Bruxer because it didn't seem clear enough. So we named it Bruxer anterior to make it clear that it goes in the anterior. And then we have a doctor requesting Bruxer anterior from a second bite to a second molar on the lower. And it's tough to say. I don't have the scan sitting in front of me. I just grabbed it before they scanned it in. But it's tough to say whether or not there's enough room here. The minimum reduction, as you've heard me say a bunch of times for regular Bruxer, 0.6 of a millimeter, but it's 0.8 for Bruxer anterior because it's not as strong. And the reason it's not as strong is we had to alter the physical properties to make it more translucent. The good news about that is that it is easier to cut off, and it's still, it's right around half the strength of regular Bruxer, which still puts it about 50% above Emax, for example. So 650 megapascals of flexural strength versus, say, 400 for Emax and, say, 1150 for regular Bruxer. So we're still getting doctors requesting a lot of Bruxer anterior in the posterior. So apparently that name wasn't quite enough to indicate it. Now for single units, it's fine back here, most likely, because anything above 400 megapascals can be cemented as a crown. For a bridge like this, that's probably a stretch. Time to use the regular Bruxer, and I don't know, it's not like the regular Bruxer is that awful looking these days. I mean, do we really want to sacrifice, you know, that additional strength, almost twice as much, back here in the posterior on a bridge just for slightly better aesthetics? You know, we would never consider doing an Emax bridge back here. Of course, it's not indicated for that, but we don't need that much in terms of aesthetics on a bridge like this. So we're still trying to kind of get that message out about the anterior material, that yes, we can use it in the posterior for single units and maybe other places, but it's really kind of intended for the critical aesthetic areas on anterior teeth and bicuspids. Here's another one where instead of using a double arch tray like we saw in the first one, and of course one of the benefits is if the patient bites correctly into this, and I love this tray, that's the Quad Tray Extreme from Clinician's Choice. If they bite correctly into this, it's a pretty darn good bite. It's not great because we don't have enough adjacent teeth for something like a bridge. And some people, I've even heard Gordon say you shouldn't use a double arch tray if you're prepping the last tooth in the arch. So even if you're just doing the second molar, there's talk that you shouldn't use a double arch tray like this because you've prepped the last tooth in the arch and seating of the condyle, that you should go with full arch impressions, or certainly something bigger than a double arch tray where the patient's coming and biting together at the same time. But otherwise, that's a very accurate way to do it. And now we have a doctor who is taking separate impressions and also enclosing a bite registration along with that. But we're not even getting the benefit of the double arch tray here, but we're still using very short impressions instead of full arch for this particular bridge. And so at least when the violation is made with the double arch tray, we get a little bit of a better bite perhaps than when we do them separately like this. But if you're just going to take separate ones like this, boy, it's so nice and makes our job easier and ultimately your job easier when cementing the bridge if you just used a full arch tray, even plastic stock trays like this, to give us that full arch. And those are actually both of the prep arch, but the opposings essentially the same size. And let's look at this model when it was poured up. And you can see how difficult this is going to be for the technicians because of how these teeth are coming together. These are crowns. These are all crowns on the top, so we don't have the benefit of the wear facets like we do on natural teeth. Yes, we have a bite registration, but we're still, guessing just a little bit here as we put this and do our excursions. So both of these really, neither of these are something that technicians like working on. Both of these should have had full arch impressions and a separate bite registration, just so we have all the other teeth on the other side to make sure that all those unprepped teeth, to make sure that we have our bite correct, and when we go through our excursions, it's going to be correct. But both of these kind of suffer for that same fate, just not enough other unprepped teeth in the arch for us to use to really be able to dial in those excursions. But again, on this one, at least if the patient's close together and there's natural teeth with wear facets, we feel a little bit better about getting centric correct. It's still anyone's guess whether or not we're going to be able to nail the excursions. But both of these really should not be done with double arch trays. And so that's what the technical advisor wanted me to pass on today. Just kind of a reminder that when doing any kind of bridge, and that's the same thing that Gordon's always said, that you can use a double arch tray for a single unit crown or 2 adjacent single unit crowns. But when you get to a 3-unit bridge or bigger, you're giving yourself the best chance of having a bridge that drops into place and doesn't need any adjustments, with a full upper, full lower impression, and a separate bite registration.
Thank you for that, Dr. D.
You're welcome.
Now let's go to a segment we call Viewer Mail. In this week's Viewer Mail segment, we actually have 2 different letters because they're short. The first one comes from Dr. Joe Ramos, and he writes, "Dear Dr. D and Megan, I'm a big fan of the Chairside Live video series. Thanks for helping me become a better dentist. My question is this: what do you use to reline the biotemps with? Can you use structure from Voco? Hope to attend a lecture with Dr. DeTola in the near future. Any chances of you coming to the Midwest? Thanks for the great videos. Joseph Ramos from Indiana," in all caps. A nod to my error of mistaking where some past viewer mails have come from.
That's funny.
Yes.
Joe, good question. Let me answer them in reverse order. Am I going to be in the Midwest anytime soon? Well, actually, 2.5 weeks from now, on June 19th, I will be lecturing on behalf of Gordon Christensen, name drop, and CR. I'll be doing a lecture for CR, one of the dentistry update lectures, in Oklahoma City. I think that's in the Midwest.
Yeah.
Is it not in the Midwest?
I would say so.
I'm not sure how to roughly define the Midwest, but I think that's
I think that counts.
in the Midwest. But it's weird because Midwest is kind of the middle of the country, right? Mm-hmm. So that's really not Midwest. I mean, it's kind of like mid.
Maybe it's halfway to the West Coast.
Like Wichita, I think, calls himself the Mid-Continental Airport, like it's right in the middle. So that's not close to Indiana, but that's the one date that pops into my head is the Oklahoma City date in 2.5 weeks, just because I was working on that presentation for Gordon's group. And I don't know the driving distance from Indiana, so it's not required that you attend to keep your dental license, but it would be nice. I would love to see you there. Now, as towards your question of what to do and how to reline a biotemp, when I first got here, everything that we used to reline biotemps was methyl methacrylates because it was the one material that would bond to the biotemps. And when I started using bisacryl products like the one you mentioned from Voco, which will work, the biotemp department told me that's not going to work because it's not going to bond to the biotemp material. And whether or not that was true, I never got a chance to find out because anytime I relined biotemps with it, it never came out. So whether it was mechanical retention or whether it was actually some sort of chemical bond, I had many years of luck using bisacryls just like that, like the one you mentioned, Structure from Voco, without any problems. The issue is, with a methyl methacrylate, you get the opportunity to kind of pump it up and down and make sure you're not going to lock it into place. The reason this happens is we take a multiple unit biotemps, let's say a 10-unit biotemps bridge, and now it has to draw with these preparations, but the preparations are for single unit crowns, and so those don't necessarily have to draw with each other. So it is possible with the bisacryls to lock a biotemps bridge into place because they go from unset to set pretty darn quick. And once they start to set, if you try to pull the average bisacryl, if you take the bridge and pull it off, it'll crack the bisacryl if it's not completely set. So that's the big advantage of the methyl methacrylates, even though they stink. Nobody likes the exothermic reaction and all the other stuff having to do with them. So one nice little middle ground is from DMG America, the people who make Luxatemp. They have a product called Luxatemp Solar. And this is what I've currently been using to reline my biotemps. And the interesting thing about Luxatemp Solar is you put it into the biotemps and seed it onto the teeth. It sets on its own to a kind of a doughy stage where you can still kind of pump it up and down, make sure there's no undercuts. In fact, you can take it out, do trimming with scissors if you want during this doughy stage, or even a disc, and then put it back in the mouth and make sure it all looks good. And then when it looks good, you take it out and light cure it, and that's the final cure that brings it to its final hardness. So Luxatemp has had Luxatemp Solo for a long time. It's just never really caught on because A, their other products are so good, and B, it's almost kind of a niche product that unless you're doing something like relining lab fabricated provisionals, you probably don't have a need for it. So if you haven't given it a try, give Luxatemp Solar a try. And it's solar, you don't have to go outside for it to cure under God's curing light, the sun. You can take a regular curing light and cure it yourself, and then be able to do any last finishing that you want to do once you've got it down and know it'll come on and off the teeth. So give that a try.
All right, and then our second question comes from Dr. Omar Osman from Miami Shores, Florida, and he writes, can I ask what would be the best way for me to help the lab tech to maintain a level occlusal and incisal plane, because my last bilateral posterior bridge had teeth aesthetically longer on one side, but the bite was fine. Thank you.
Well, Omar, it's a little easier on the anterior, because we can take a bite registration on the preps, and then we can put a stick parallel to the inner pupillary line and make it easier for the technician to see. But when you're talking about it for bilateral posterior bridges, now we're talking about, you got a case back, it sounds like, from the lab that had a curve of Wilson violation. And I don't know who Wilson is. I always wonder who Spee is, the curve of Spee. Of course, when you combine those two, you get the sphere of Monson. That's pretty cool. I don't know who Monson is. There's also the cusp of Carabelli. Sounds like a nice Italian boy. And that's why I'm always hoping to find something that I can call my own, a curve or a sphere of Datola, or even a cusp of Datola. I'm always on the lookout for little things where I can stake my claim and then copyright it like Pat Riley did three-peat and hopefully get paid. So it sounds like you had a curve of Wilson violation, and that's the one as you go from side to side that looks like this. Curve of Spee's anterior, posterior, and then medial-lateral is the curve of Wilson. And of course, when you view that, the posterior teeth on the upper are tilted out towards the buccal so that the lingual cusps appear to be longer than the buccal cusps. And so this is really something that you don't have to indicate to your dental technician. In fact, there's really no way to indicate it, and you shouldn't have to indicate it, to be honest. That said, it's something that I see happen here at the lab, and it's technicians getting a little overly cute with anatomy on the buccal cusps, and they start hanging down farther than they should. And the whole reason for that curve of Wilson is to make sure that when the teeth slide around that they follow the path that the condyles want to take, and we have room for that. And those long buccal cusps will absolutely get in the way, which is why the curve of Wilson exists. But you shouldn't have to do anything. If the technician's a younger technician is struggling with it, it's very easy to see if you take one of those metal flat planes and you put it up to whatever case you're doing. If you've got two bilateral posterior bridges, and you should see the lingual cusps of those molars touching the plane, and the buccal cusp should be slightly off. And when you look at both sides, both sets of buccal cusps on the two bridges should be just the same amount off of that flat plane as each other, so that it's even and you don't get that aesthetic differential that you mentioned. I remember setting up dentures in school, and we had that curve plane where it had the curve of Wilson and curve of Spee built into it. You know, that curve plane could also be set on that arch to make sure that you've got the correct inclination on those upper molars to make sure that those buccal cusps do appear higher than the lingual cusps. And it sounds like the lingual cusps were in the right place, and that's why the bite was fine. So in the anterior, when it comes to incisal plane, absolutely, you can give a stick that parallels the inner pupillary line, but on the posterior, there's really nothing you can do to help your lab tech out besides say, hey, do me a favor, don't violate the curve of Wilson, but like I said, you shouldn't have to say that in the first place. I just know, seeing our technicians here, it is something that happens because it seems innocent enough as technicians are building teeth and making it look good. It happens a lot less today in the CAD/CAM world because now all of our designs are based on ideal tooth shapes, and it's not somebody manually adding wax. So if this is a lab you're using that's not necessarily designing in CAD/CAM, maybe you do want to mention that this happened, take a picture of it and say, could we try to make sure that we hit this curve of Wilson next time and see if we can't get it right on. So thank you for bringing that up. That's the first time I've heard a curve of Wilson question in a long time. So
nice.
Good to hear. So we have a couple things that we can send out.
We do. Joseph and Omar get a couple things.
Okay.
How about a photograph?
Yeah, wait, what?
So I'm pointing, saying...
Oh, I thought your finger was actually like in your mouth.
No.
It's going the other way.
It's pointing directly straight at you. Then I'm pointing. There's lots of pointing pictures. I'm not exactly sure what.
Is that the international symbol for something?
I'm awesome.
Yeah, okay,
Yep,
I guess
okay,
that's
I'm
what
awesome.
it is. The I'm awesome
And
pose.
then this is, I'm a little skeptical of whatever you're saying.
Right.
And then, wow,
Oh,
thank you.
wow.
Thank you, producer James, for a picture solely of myself
I want
looking
that one.
obnoxious.
I want that one.
Wow.
And
And then cut out to the large shot,
that
the
looks,
same photograph,
right.
just with you in it and it zoomed out.
Right.
So out of all of
That
those,
looks like a Saturday Night Live character.
yep.
You're happier than Debbie Downer. I'm not sure who it is. You're not the lady with the baby arms. I don't know which one, but
not the lady with the baby
it
arms.
reminds me of one of the characters.
I
I
don't
like that
know.
one. I almost think we shouldn't change and just stay on that one forever. But
Okay, well, you know what? We'll talk about it later
we'll
and
go through a
decide.
very long and exhausting scientific process
Yes,
to figure
of
out
what
how
we
we're going to decide
choose.
which pictures and
Yeah.
which burr kits you're going to get as a gift. Well, thank you. Any
Yes.
news today?
Yes. In a stomach-churning new study, researchers found that there's a 60% chance your toothbrush is covered in feces. Share a bathroom with others? Well, 80% of that waste matter belongs to them. And that's the problem. When a toothbrush is contaminated with fecal matter from someone else, which contains bacteria, viruses, or parasites that are not part of your normal flora, decontamination efforts prove to be less than effective. All of the toothbrushes regularly rinsed with mouthwash had growth indicating fecal contamination. Want to know what's worse? That even if
Nothing.
that even if you put those little, supposed to be protectors on top of the toothbrush to
Right.
keep it, that they said that actually makes it worse because you're creating this warm, moist environment where the
Right.
toothbrush can't dry out, and so then just morph.
It's dark, warm. It's
Right.
like growing mushrooms. It's now dark,
Poop
warm,
mushrooms.
and moist. Yeah, exactly. Wow, that's That's I guess the problem is brushing our teeth in the bathroom, right? I mean, this needs to be an activity moved to what? The kitchen?
The kitchen
or
sink?
another sink or something like that?
I don't know, but okay, so maybe a little too much information here, but my protocol for bathroom use is when I'm done, when I flush the toilet, I always put the seat down, or the lid down. That way, thinking that it would block any sort of airborne, because they were saying that it's when you flush, that's the problem.
Oh, they did say that. Oh, so that way it's just your husband's fecal matter you're brushing your teeth with and not your own mixed in.
Duh. Yeah, so anyway, that's what I do, thinking maybe that would maybe eliminate at least most of the...
Interesting. So it's the flushing part. I guess it creates some sort of
It
aerosol.
Right, it makes them go airborne
Wow.
and land on your toothbrush.
So if they, that's interesting. Well, hopefully they'll do a study where if you close the lid first,
Right.
like on an airplane, and then flush, if it still happens or not. I feel like it still would.
Yeah, I
I don't know. It doesn't seem like there's a big aerosol. It's not like it's one of those insane Japanese Toto toilets where it's like spraying
Right,
you
right,
and
right.
all that stuff. I mean, it doesn't seem like when you flush a toilet, it just kind of, the movement starts, but there's not a lot of agitation or...
And this study comes out on the heels of a different study that's said, I don't know if you read it, you don't have facial hair, but that they said that beards have more germs than toilets,
Really?
more fecal bacteria than toilets.
Take that, hipsters.
That's right.
Shave that
Dirty.
disgusting pelt
Yeah.
off your chin. Well,
So,
you know,
nothing's safe. Our toothbrushes, our beards.
for most people, dry brushing works just as well as regular brushing. I mean,
Right.
the toothpaste makes it, taste good. But people who have what we've called abfraction lesions, those wedges at the gingival margin, there's a huge school of thought that it's due to not toothbrush abrasion, but toothpaste abrasion. And so if you take the toothpaste out of it, there's not really a need to spit anything. And a lot of times I'll sit with my toothbrush, watching the news on the couch, whether it's the Sonicare or the manual one, and just kind of brushing there. You tend to brush longer because you're not standing chained to your sink.
Right.
And watching it, when you run your tongue across your teeth when you're done, they're just as clean, if not more clean, because you took more time and maybe were a little more thorough than standing at the sink and having all this foaming kind of going on at the same time. So I wonder if there should be a movement to move it out of the restroom, or I don't know if it really causes.
I don't know.
What about when, like, our master bathroom has the two sinks here on the counter, and then the toilet itself is in a room where the door always gets closed?
Oh, I
Is
think
it possible for the feces to come out, hang a right, and hang another right?
It depends on how determined they are. I don't know. I think that would probably block most of it, you'd think. It's in essentially a different room, but they might be pesky little suckers. You never know.
Right.
They could come on out and find your toothbrush.
Right. I was actually part of this study, and I just thought of it now. I forgot to mention them. I'll often use the other people in my house as toothbrushes to clean the toilet if there's a stain or something, which I forgot to mention.
Well,
That might have been important.
Well, that's fine because the stuff on your toothbrush isn't yours anyway, according to the study.
Wow, interesting.
So right back at you.
Well, that's an interesting one that I don't know there's any way around it, especially here at the lab in the employees' bathrooms. That's a lot of use, a lot of flushing going on, a lot of other noise, and a lot of people brushing and flossing in there. That's kind of crazy.
From the first story to now this story, I think I'm skipping lunch today.
That's true. We're backing up against lunch, and it looks like we're going to skip it. Well, what a great way for you and I to look just a little more fabulous on next week's Chairside Live.
No butter today.
That about wraps it up for this week's edition of Chairside Live. On behalf of myself, the lab, Megan, and all the crew here at CSL, we want to thank you for your time and your continued commitment to quality dentistry.
We'll see you next time. And forget giving the toothbrushes to your patients. You're going to want to... I was so close. I had it, and then it just left like the poop out of the toilet onto my toothbrush. Isn't that who does? Huh. Wow. Production lingo, it's fine. Got it.
Well, thank you for that.
That's not it.
What?
We've got more. One more story.
Well, that's one thing dogs do that kids don't do, that whole before it happens. A lot less drama. There's also the cusp of Carabelli. Sounds like a nice Italian boy.